Good afternoon to our friends on the East Coast, and good morning to our friends on the West Coast. Welcome to the AMCHIP webinar entitled Definitions and Trends in Preterm Birth. My name is Jonathan Webb. I'm the CEO of AMCHIP, and on behalf of AMCHIP, thank you for joining us and giving us an hour of your time today. We are delighted to have you. This webinar is the first in a four-part series titled Engaging the Power of Title V to Understand and Intervene in Preterm Birth. We're excited to be partnering with the Pritzker Children's Initiative to bring you this webinar series. It's been designed to increase awareness and understanding of opportunities to improve outcomes for the mom-baby dyad and prevent preterm birth, as well as inform opportunities for MCH programs to respond to the results of the Title V needs assessment process. As Title V and maternal and child health leaders across the country, you play an important role in offering and executing essential services that impact the health and well-being of women and children around this nation. Preterm birth has been a signature area of focus for Title V program efforts to address infant mortality since the inception of the program, and preterm birth is a national outcome measure for Title V MCH block grant. For this reason, you truly are leaders in preterm birth prevention. Through this webinar series, we will highlight current trends in preterm birth. We'll discuss emerging research, explore data sources in innovative ways, and we hope to highlight programs that successfully prevent preterm birth for you. With the increased turnover in Title V and the changing context around the conversation of preterm birth, we felt it was really important, vitally important, to refresh and recenter on this critical MCH topic. We hope that this series re-engages you, piques your interest, raises questions about the role of Title V, and introduces you to impactful, equity-centered approaches. And if you're interested in partnering with us and putting these ideas into action, we're exploring structures for doing so, and would love to hear your thoughts after the call. Thank you again for your time this afternoon and this morning. We look forward to the great work that's going to come out of this group. And with that, I will turn it over to Jessica Steiger, who's our program manager for infant health, to begin our program. Thank you, Jessica.
Thank you, Jonathan. All right, folks, before I get into the specifics about our agenda and turn it over to our wonderful speakers, I have a few housekeeping reminders. So all of your phones have been muted at the start of this webinar, and that's because we have a large group and we do want to minimize background noise. However, we will open up the phone lines for questions and discussion towards the end of the presentation. If you have a question for our speakers, you can unmute yourself by pressing *6 on your phone. And when we aren't in specific Q&A time, I just ask that you feel welcome to enter questions into the chat box in the lower right-hand corner of your screen. And we will monitor this box closely and either ask questions on your behalf or we can queue you up to ask your questions for the speakers. And you can also use the hand raise option or otherwise communicate with us, for example, telling us to slow down or speak louder using one of the icons in the drop-down menu at the top of your screen or by entering that into the chat box. And if at any point you're experiencing technical difficulties, please feel free to chat us directly in the chat box, or you can email my fabulous colleague, Bijan, and her email is up on the screen there. Okay. Above the chat box in the right center of your screen, the top right of your screen, you'll notice there's a file share pod, and here you can find the speaker's slides for today, and you can also see the full 2019 March of Dimes report card and a short document about the Pritzker Children's Initiative. To access any of those documents, you just select the document you want to download in the list, and once it's highlighted, you can click the Download Files button and download it through the pop-up box that you see up here. And again, if you have any challenges with that, don't hesitate to send us a chat or email. Please know that today's webinar is recorded, and we'll be making the recording available on our website, and we'll also directly email those to registered participants following the webinar. So you're welcome to share the webinar with any of your colleagues, of course. And one final housekeeping item, please do take a moment to complete the webinar evaluation at the end of the webinar. A link will be included on the last slide of the webinar today, and you can also access it immediately following the webinar and when we distribute the meeting materials once we've concluded. So, with all of that being said, let's move on to our program. We have some wonderful speakers to assist us in achieving the following learning objectives for today's program. So today we're really going to focus on learning about the current trends in preterm birth, its relationship with infant mortality, and disparities in preterm birth outcomes. And we're going to develop a deeper understanding of those current trends in preterm birth and the methodologies and processes behind the March of Dimes report cards and how those report cards really impact Title V programs. We're going to cover a lot of content today, but please do know that we've reserved the last at least 15 minutes of the webinar for direct Q&A with the participants. And we're also excited that the March of Dimes team will be staying on the webinar for an additional 30-minute long office hours. For that, we're going to turn off the recording and open up the phone lines for any state-specific questions that you might have about the March of Dimes report cards. So due to the very tight agenda we've got and the many objectives we're hoping to achieve for you today, we're not going to present full bios of each speaker, but I do want to briefly introduce the wonderful group of speakers for today. So today we're going to be hearing primarily from Dr. Lisa Waddell and Mr. Roland Estrella. Dr. Waddell is the Deputy Medical and Health Officer and Senior Vice President of Maternal and Child Health and NICU Innovation at March of Dimes. And prior to joining the March of Dimes, she worked with the Association of State and Territorial Health Officials and as the Deputy Commissioner for Health Services for the South Carolina Department of Health and Environmental Control, the state's public health agency. Mr. Roland Estrella is the Senior Director of Science, Data Evaluation, and Innovation at March of Dimes, and he leads the March of Dimes Perinatal Data Center, the March of Dimes Center for Social Science Research, and the National Birth Defects Reporting with CDC. Before joining the March of Dimes, Roland worked with state leaders in Florida to evaluate family planning services, develop passive surveillance for birth defects, and integrate maternal and child health data. And then during our office hours portion, you'll also be able to talk to Dr. Ann Davis, a research analyst with the March of Dimes, who is responsible for a great deal of the research that goes into the March of Dimes report cards. So, without further delay, I'd like to turn the floor over to March of Dimes. So please make sure for our speakers that you press *6 to unmute yourselves, and you should also be able to advance through your slides now.
Well, good afternoon and good morning. I am Dr. Lisa Waddell, and it is really an honor for me and my colleagues, Roland Estrella and Ann Davis, to join all of you today on this very important webinar. We are pleased to talk about healthy moms and strong babies and to provide tools for you as MCH professionals to address prematurity. The objectives, as you have heard from Jessica, are to highlight the March of Dimes as a resource to Title V directors and your teams, to describe current trends in preterm birth, its relationships with infant mortality and disparities in birth outcomes, and then thirdly, to describe the March of Dimes report card and peristats as tools. We want you to know that you've got these tools available to you to help you in your day-to-day work. We are so proud and privileged to wake up every day, like all of you, and to work on behalf of moms and babies all across this country. The March of Dimes, our mission is to lead the fight for the health of all moms and babies, but we are very clear. We know that we cannot do this alone, and we don't do this work alone. We do it in partnership with you and your counterparts in states and communities all across this country. We have a bold vision for moms and babies. It's about healthy moms and how do we end preventable mortality and morbidity impacting moms in this country. And it's about strong babies and how do we end the preventable prematurity and infant mortality that's happening in this country. And then we know we've got significant disparities that cut across these issues. So how do we achieve equity as we work on these important, bold goals here in this country? Why do we have these bold goals? Well, the U.S. has a maternal and infant health crisis. It's not two crises, it's one. The crisis is about moms and babies together. It's about those that we have lost, including moms who died and those who faced serious health challenges before, during, and after pregnancy. We all know that there are faces, names, feelings, hearts, all behind these numbers. 22,000 plus infants are dying in this country each year. 1 in 10 babies is being born preterm. And preterm birth is steadily on the rise, and that is very concerning. A woman dies every 12 hours as a result of childbirth in this country. And the U.S. is among the most dangerous developed nations for childbirth. And when we think about the disparities that exist, Black women are 3 to 4 times more likely to die from pregnancy. So we have a crisis, a maternal and infant health crisis here in this country. This slide shows you again that we have an urgent crisis. Moms and babies are dying. On the left-hand side, you see the trends in pregnancy-related mortality in the United States, and you can see from 1987 to 2016 that those rates are steadily increasing. And then on the right-hand side of the slide, you see the U.S. preterm birth rate has increased again in 2018 for the 4th year in a row. So you see where we had a low of 9.57, and it's been steadily ticking up over the last 4 years. This impacts 380,000 babies each year. We have a crisis. Again, nearly 4 million babies are born in the U.S. Each year. Nearly 380,000 of these babies are born preterm. So that's too soon, less than 37 weeks gestation. We know that birth defects remain a real challenge with babies and contributing to infant mortality. 116,000 plus babies born with a birth defect each year. This issue is costing us a $26.2 billion at least dollars. So preterm birth has a real societal cost as well. And now I will turn it to Roland Estrella.
Good morning and good afternoon, everyone. I think I hear an echo. No, not anymore.
I think you might be talking through your phone and your computer. Is that possible?
I think I'm good now. So thank you, Lisa, for starting the presentation, and we wanted to go ahead and start with showing data, but addressing prematurity within the context of infant death, and this is data that the March of Dimes developed for the 2016 year, but it's still relevant. And what we did is we sort of grouped preterm birth-related causes within infant death, and basically what we find here, we're reporting here, is that more than a third of infant death are prematurity related causes, which is a significant number, and as a single cause, prematurity and low birth weight has the second leading cause of infant death, and birth defects, as we know,
is the leading cause of infant death, and we're very privileged to work with the CDC also on birth defects prevention. So wanted to start with this and showing how relevant prematurity is within the context of infant death. Then when we look at gestational age, so the earlier the baby is born, the higher the risk for infant death. So here on the horizontal axis, you have gestational age in weeks, and we start counting at 28 weeks. Is very early preterm, it's less than 32 weeks. So we start counting at 28 weeks, and then the rate of infant mortality per 1,000 live births, just start at 64, and then start decreasing from there. But this is sort of, again, to highlight the relationship between gestational age and infant mortality and how this rate is 8 to 7-fold higher as the babies are born sooner. So it is an outcome of infant death is an outcome of prematurity that is pretty significant, and we definitely it's the way to start because just taking it back to what Lisa presented, it's 22,000 babies dying, and one out of 3 of those babies that died because of prematurity. Then just to ground it more, prematurity has a high cost. Low birth weight, underdeveloped organs and organ systems, increased morbidity, there's breathing problems and respiratory distress and life-threatening infections. There's disabilities, what we were saying about the birth defects, which is, again, tied to prematurity, also leading to infant death. And blindness and death, learning and developmental disabilities, plenty of literature showing how prematurity is a risk factor for a lot of developmental disabilities and mortality, which we reviewed. And then the impact on family in general, health and over the life course, a premature baby, it's not as healthy as a term baby, and there are many studies and a lot of research that I'm sure will come in subsequent webinars in this series that will show all of this impact. So with that, let's start digging into definitions of preterm birth and more of the data behind it. Preterm birth is not all one thing, and I think this is key because we need to understand how it breaks down so that we understand the parts within preterm birth that are increasing and what forms basically the crisis that the country is in. So this is a visual showing a time axis of the pregnancy, and basically we have for preterm birth we have late preterm birth, which are babies that are born between 34 and 36 gestational age, and less than 34 weeks of gestational age. It's very preterm and preterm. So late preterm is 34 to 36, and early preterm is before 32 weeks. And again, as we'll see, the causes of preterm births, and we'll see that in other webinars, are different for these ages. A baby that is born, let's just say at 31 weeks is much less developed and has much more risk to be born with birth defects than a baby that is born at 34 or 36 weeks. So this is important because it'll drive some of the disparities and some of the trends as we move on. So this is the graph that Dr. Waddell showed of increasing preterm birth rate. The preterm birth rate is the number of babies that are born before 37 weeks of gestational age, and the denominator for that is all live births. So, for example, a way to read the preterm birth rate is 10 out of 100 babies in 2018 that were born preterm. As we can see, we started this trend from 2007, and then the trend, the prematurity was decreasing from 2007 until about 2014. And there are studies done by CDC and other partners that show that young age and declining teenage birth rates have to do a lot with that, because some of those babies were born premature. But then starting again in 2015, we've seen an increase. And at the March of Dimes, every day we try to understand and try to find explanations and share this information with our partners to see what is it that is driving the increase, and how can we all together address the increase and understand it. So this presentation and this series of webinars is an effort to do that. It's just to understand what's happening and what can we do about just bringing this trend down again. Then going back to categories of gestational age, right? So we have the late preterm birth, we have the preterm birth, and the very preterm birth. Different problems, different outcomes. We have to look at them different. So we made this visual just to put it in that perspective and show you that the majority of preterm births are born 34 to 36 weeks. The causes are different. The maternal conditions at that gestational age are different than the babies that are born less than 32 weeks, which is very preterm, and the babies that are born 32 to 33 weeks. So for the majority of those babies, this is about 72%, the larger portion of the distribution. 72% of the babies are born late preterm. And this is exactly sort of the same concept, but broken down just so that we see the increase or the decrease. So this is a trend of how these categories of gestational age are increasing and decreasing. And when we compare data from 2016 to 2018, we see that there hasn't been a significant increase in babies that are born very preterm or preterm, 32, 33 weeks gestational age. The increase has been significant and only in one category, late preterm births. And this is very key, because now as we try to understand this crisis and this trend that's going up, we know where we can focus. We know we need to focus on that 34 to 36 weeks. So this is very important. We've seen a 3% increase in the last 2 years, and that 3% increase in only the category of late preterm, it's what's driving the total preterm birth, the less than 37 weeks. So it's like a total preterm birth has increased by 2%. Then there's disparities. And disparities is part of the increase, and we always need to start by race and ethnicity, because we know one of our goals and one of the things we need to understand is why does it vary by race, and there are many research and many studies addressing this, but it's always part of the conversation, and it needs to be highlighted. And here we can see that Black non-Hispanic women are still having a 50% more likely to give birth prematurely compared to white women. There's many things to understand about that, but at least just having the data and seeing it in this way, it helps us to focus our questions and our reasoning towards the reasons that are driving this crisis. Here is how it's changing by race and ethnicity. So we saw that it's been going up since about 2015. It's been going up for the 4 years. So how is that changing trend being represented at the race and ethnicity level? We see here that on the white non-Hispanic population, yes, there's an increase, but it's very low compared to the increase for Black and Hispanics. In fact, I think it's like fivefold. The difference is fivefold regarding the increase between 2016 and 2018. there's a small significant decrease in the Asian and Pacific Islander population. But I think the ratio of the difference in the increase on the Black and Hispanic population compared to white, I think that is a significant statistic that can drive our focus as we understand our states and our community. Then, in an effort to report this data and make it available to you and get the conversation going and get the partners together and mobilize all of our resources towards understanding that crisis and taking action. The March of Dimes produces the report card every year. And the goals of the report card are to highlight the rising in the preterm birth rate. That's why we do a great change over time, and we report whether that grade went up or down or whether it stayed the same. Excuse me. We designed the report card to raise awareness and highlight the disparities and the mortality and morbidity for women and babies of color. We underscore the interventions, the campaigns and programs that are in place to come back to issues, and we help motivate and activate public engagement and advocacy. So the purpose of the report card is just to have a year-to-year document that we can see for our states, for our counties, for our cities. Are we part of the increasing trend or are we not? And get sort of the conversation going so that the right questions and the right discussions are taking place. This is a map that summarizes the results of the report card for 2019. For the first time, we were noticing that the changes in rate for the states were very small, and some of the states that were making a lot of efforts to reduce preterm, they were being successful to do that. But since the improvement was very small in the previous grading category, we were not capturing that in the grade. So this time we added sort of a larger spectrum of grades, introducing the incremental grading, the pluses and the minuses within the letter grades, just to try to capture those small successes, because that's relevant, because that tells us, if it's working for that state, would it work for other states that are not seeing a decrease in preterm birth? We see that the F states are in the southeast region there, and there's some A states, and this map, and you can look at it more carefully. We'll make this link available on our website, but this is how the grading is distributed on the 2019 report card. Then this is a United States report card. Here we are showing on the left, which is the first page, that the United States has a C for a grade, and the preterm birth rate in the latest birth cohort that we processed, which is the 2018 birth cohort, the rate of prematurity was 10%, and we see on the pink line, we see the increase that we were showing in the previous slide. Then we have the map showing the distribution of grades. But what is new in 2019 is we said, look, it's not two crises. It's not a mom and a baby crisis, one crisis. The health of the moms and babies is connected. Things that happen to mom could determine whether baby is premature or not. We need to be thinking as a country that women and baby both need our thinking and our resources. So we said let's just add maternal health, and let's call it the March of Dimes report card. It's one problem, it's one crisis. So we need to be looking at the context of the health of the mom. We need to be looking whether women have the right access to health care and whether they have insurance, so that they can feel that economically they can afford to be pregnant. We need to look at things like adequate prenatal care and the number of prenatal visits that moms are having. Inadequacy of prenatal care should not be acceptable. We need to look at economic factors, including poverty. So addressing social determinants of health and putting them next to our analysis of prematurity, we believe is the right way to understand and continue the conversation around prematurity. Mom, healthy mom, strong baby. We need to be addressing mom's issues preconception and after pregnancy. And then we said, well, it's the social determinants, but there's also costs associated with that. So we need to help states see the crisis also from a cost perspective. So we funded a study to do a refresh of a cost of prematurity study that was done by the Institute of Medicine in 2005. Marcia Dimes funded the same researcher from University of Utah to refresh this and put these dollar amounts in more recent numbers, and we basically are reporting the average cost of a preterm birth. $65,000. $65,000. What just happened? Jessica, the PowerPoint slides went away?
Yes, I see that.
Okay.
Oh, wait.
Here we go.
We got it. Sorry, I don't know how that happened.
Thank you. So we looked at the cost of a preterm birth, and again, the average cost nationally of a preterm birth, a baby born before 37 weeks of gestational age, we found to be around $65,000 compared to a normal delivery, which is there are many references like that, but what we found is that it's at least a six-fold increase in cost. Then we said, well, so that's what a prematurity costs per state, but let's also report on the maternal and child health block grant dollar amounts. So we worked with HRSA to get the latest funding amount for the MCH block grant, and we included that in the maternal and infant health context and actions page, just so that we have a perspective of how much is prematurity costing, and what are the resources that states are getting for one of the federal ways to get support to address problems, including prematurity. Prematurity is not all, but like we said, tying it back to infant death is a third of the babies that die. Then we went into insurance and Medicaid expansion, and we worked so that we reported the states that expanded Medicaid versus those that did not expand. There's some studies that have associated improvement in disparities due to Medicaid expansion. So we thought that was a critical component of the report card that would show where each state is regarding Medicaid expansion. And then we sort of gave a preview of the direction that the Marcia Dimes is taking regarding some of the things that we believe are working in states to address maternal and child health issues centering around prematurity and maternal mortality. And I think we have a slide later, and I'll go into more details of what are recommended state actions. This slide is showing you an example of one state report card. The The difference is that here we show the disparity graph. So we show the disparity ratio and how race ethnicity is for blacks. For example, in this report card for Ohio, blacks are 49% higher rate than of the other women combined. Within each state, we also show some of the counties, of the highly populated counties for each state, and we also calculated grades and birth rates, and we have an indication there whether the rate worsened or improved based on the last year. So there's a measure of geography here. Here we go into more of the sense of the local communities and how those grades compare to the aggregate state rate, and then within each of those communities whether the rates are increasing or decreasing. And then we include 6 counties, and we also include the most populous city. It's based on number of births, not in population. Just to go again to the local, and later in the presentation we'll go more into why small geographies and why looking at county and city and community data is so important. So this is a sort of a high level, again, to mobilize, to generate awareness, to have people talk, and to have people understand that communities, changing and improving or worsening have influence on the state rate, but each community has its own definition and issues with disparity and prematurity. So that's very important. And then the other page is, this example is for Ohio, that the average cause of preterm birth is $3,000 less than the national average. There's the amount for the maternal child block grant, and this is showing that Ohio adopted Medicaid expansion. So let's review more closely the recommended state policy actions of the March of Dimes is reporting on the report card. We believe that extension of Medicaid coverage for all women to at least 1 year postpartum is critical because it's one crisis, not two. The maternal mortality rate in the U.S. is increasing, while in the rest of the world is decreasing. Why is that? We believe that by ensuring that women have access to health care beyond the 60 days, which is in the majority in the states that have not implemented, extension of 1 year postpartum. 60 days is a norm for losing Medicaid coverage. We are advocating to extend coverage for all women 1 year postpartum. Group prenatal care enhanced reimbursement. Group prenatal care has proven to positive outcomes. There's studies and there are evaluations done that there's increased benefits in Black women who participate in group prenatal care. Includes delivery and outcome-based incentive and can encourage providers. So this is a model that we are supporting and we believe it should be adopted. And then the MMRCs is the Maternal Mortality Review Committees. This is a CDC-led initiative where states working with CDC collect and analyze data around maternal mortality and report back, on the issues of preventability, right? So how many of those deaths and how many of the maternal health issues that we have during that postpartum period are preventable. And that effort also needs all of our support, and we're highlighting that as recommended state policy actions in the report card. Again, let me get back here. This is sort of the bottom section of the report card, and what we say there is moving forward in 2020 for the 2020 report card, the March of Dimes is going to go and have more in-depth information for each state on these issues. So then I wanted to get a little bit a sense on what the methodology for the grading is, and it's a very simple breakdown of the rate of prematurity. Again, we said the rate is the number of babies born before 37 weeks over live birth. So 10% prematurity rate means that 10 out of 100 live births were premature in 2018. So for each of those ranges, what we had before was based on the March-Dimes goal. The March-Dimes goal up to 2019 continued to be to reduce the preterm birth rate. So we took the standard deviation of that and we split it into letter grades, and then to do the incremental grading, which was introduced in 2019 of pluses and minuses, which is divided the same range that we had in 2019, but we divided by 3 just to create these incremental stages. So it's essentially a way to distribute the ranges in rate that we see across the state in a way that lets us group states by where they are within their rate compared to other states. And, you know, we're going to have office hours, and if we need to give you a more technical and detailed explanation, we're happy to. So we're open for questions. Moving on to PERI-STATS. PERI-STATS is sort of the deep dive of the report card. So report card is a mobilizing tool. It generates awareness. Everybody, the general public should look at it and say, well, why does my state has an F? You know, and why do states have an A, and what's the difference, and why? You know, to trigger all those questions. But PERI-STATS is for our health people, for the people that are, you know, interested in digging more into data and going more into the local data and answering all those questions that are not covered by the report card. That's why we built and we operate PERI-STATS. So within PERI-STATS, we can have access to birth outcomes by state. We can look at preterm birth weight, prenatal care, birth defects. We've indicators at the community level, including smoking and alcohol and poverty and health insurance. So PERI-STATS is a very comprehensive maternal and child health database, and it's there for you, and it's there for answering some of the questions, and those questions that we're not answering, that there's data for. We need to hear back from you and say, you know, why don't we do that? This is important. So I think this webinar is also an opportunity for that. It's just to open this connection and hear back from you. What would you like to see in PERI-STATS that's not there? We would appreciate that very much. Right now in PERI-STATS, there are a number of reports that are downloadable based on the most recent data that we have access to from one of our data sources is the CDC National Center for Health Statistics. We also work with birth defects reporting. So all of these reports are you know, downloadable and dynamically, you can have dynamic access on PERI-STATS to get to the latest report. And again, you know, if you have specific questions, we're happy to address those in the Q&A section later on. Then I wanted to close this presentation with so we have the data, and the data is helpful, but how do we mobilize communities, and how do we visualize the data so that it's not numbers and percents and rates and line graphs? How do we create a connection between the smaller geography and the local community to this data? And we wanted to present these methods, and this is not yet in PERI-STATS, but we hope it will be. It's just a way to use mapping, because mapping for some people has a way to get the information faster and for people to interpret faster, because they say, well, I know I live in this neighborhood and I know I take this road to work every day. So when I drive by that road, I wonder what would the rate of prematurity be around that neighborhood, so people can relate to the information better when you show them a map. And in my work in Florida, I work with March Dimes and with many other agencies, and we created these maps where we not only map the rate of prematurity, which is not more than 1%, but we also map the concentration of prematurity. So how many babies are being born premature, for example, in a square mile, and how many babies are born prematurity among the nearest 1,000 births in each area. We tend to look at data either by looking at counts, and when you look at counts, it basically goes into the larger cities and largest community, right? So the higher the population, the higher the count. And when we look at rates, well, we could get high rates but low counts. So those two separate. It's difficult to interpret sometimes, and it's difficult to present, stakeholders and partners and the general public two maps and try to explain what the combination of those two maps mean without creating one map that conveys it all. So this density mapping or concentration mapping is a way to get those two concepts in one visual. And again, people can relate to that. For example, the map on the left, this is Broward County in Florida, Fort Lauderdale area. And the little tiny percent you see there, those are census tracts. It's not zip codes. A zip code is a way for the post office to deliver mail. Census tracts, the Census Bureau looks at demographics and looks at more detailed population characteristics to define what the boundaries of a census tract is. They're usually uniform in count. So, the more rural the census tract, it's going to be larger. The more urban census tract is going to be smaller. But the demographics of people are somewhat more uniform than the zip code. So the rates of census tract, and then the color is basically concentration of premature babies born within a square mile. And you can tell, you can go through that map and say, where are my babies concentrated with a high rate? So you're combining rate and count in one picture, and this is something that you can show the public, and the public will get it because they will place themselves in the map. They'll say, oh, that's where my friend is, that's where I drive by every day. And with uses in cities like the agency of Florida, I mean, it's had major successes to inform a lot of local government investment. So part of our goal with this is to show that our ways to use this data that are innovative and easier to present to the public. So with that, I'll hand it back to Lisa to summarize the presentation. Thank you.
So thank you, Roland, very much for that overview of the issue and the tools through the report card and peristats available from the March of Dimes to our MCH colleagues across the country. So in summary, we think that all of you would agree that we do have an urgent maternal and infant health crisis in this country. As you have seen from this presentation, preterm birth rates are rising, and that certainly is concerning. That the disparities persist and that far too many infants still do not survive to see their first birthday. And that hopefully you've learned through this that the March of Dimes has tools to assist you as Title V directors and your teams to address preterm birth in states and communities. So we thank you for the opportunity to share this information. And now we'll open it up to questions and turn it back to Jessica.
Thank you so much. We really appreciate your our wonderful speakers for queuing up some great dialogue with our participants. So I think you have a thank you slide here with your contact info and some wonderful links for March of Dimes. And if they're at this point, I think I would like to open up to questions maybe about the data presented, trends in preterm birth, about this particular presentation. If you have questions that are specific to your state or your state's report card, I'm going to ask you to just hold those to make sure that there aren't more general questions first, and we will do the state-specific questions once we get through any more general presentation questions. So if you want to type questions into the chat box, that's a great option. You can also use the raise your hand feature up at the top of your screen. But while folks are maybe thinking about that, there were just 2 questions in the chat box earlier that I just wanted to, that I'm so grateful Dr. Davis was able to answer. And I'll just read those out, though, for folks who may not have the chat box open in front of them. So one question was about what the definition of low birth weight was, and Dr. Davis answered that low birth weight is defined as less than 2,500 grams or 5.5 pounds. And then there was another question about the difference between the Healthy People 2020 goal for prematurity rate, which is 9.4% by this year, 2020, and the March of Dimes goal, which is 8.1%. And so Debbie Kane asked, how did the March of Dimes select its goal? And I wonder if, rather than me just reading this off, if Dr. Davis or one of the presenters wants to speak about that briefly.
I can address that, Jessica. Thank you. So the March of Dimes worked with the information that we have available, and there's a lot of information that is focused on prevention and reduction in preterm birth rates. I included the article under files. It was by Dr. McCabe, was the primary investigator on that article that he put out in pediatrics. So it goes into a great amount of detail about how we came to the 8.1 number. But essentially, we looked at trends. We used data from 2 more recent years at the time that the investigation was done, so 15 and 16, I believe. And we looked at how much we could actually influence that number if several factors happened. If we had reductions in things like behavioral risk factors like smoking, if we saw the inclusion of the elective C-sections being reduced, that 39-week program that March of Dimes was so involved in. So all of that went together to model what the possibility of reduction was, and that came to 8.1%. But the article goes into great, fabulous detail if anyone is interested further in that.
Wonderful. Thank you so much. I invite folks to go ahead if you want to just unmute yourself and ask a question. You can press *6 on your phone. I saw one person typing into the chat box, so I'm going to see if their question comes through.
Hi, this is Belinda Pettiford in North Carolina. I have just a quick general question. I know we speak a lot the maternal mortality review committees, and we're excited in doing the work here in North Carolina. But what are your thoughts on states also focusing on fetal and infant mortality reviews, and, actually having FEMA reviews going on in their states? Can you speak to that at all? Thank you.
I'm going to ask, did you say fetal? Oh, go ahead.
She said fetal and infant mortality, so femurs. And so,
Yes.
yeah, I don't have, this is Dr. Waddell. I don't have sort of in front of me the current picture of what's happening with femurs in every state, but conceptually and generally, I think we all, would agree that to the degree that there are resources to be able to do a fetal infant mortality review is equally important because again, it's where you can dig into the data more and what's actually happening in the state and reviewing those cases to really get at what are some of the underlying issues that you may be able to tackle better in your particular locality. So I mean, I think that's the beauty of having these kinds of state-based reviews.
Thank you for your response, Dr. Waddell.
And hi there, folks.
I
This
know
is Andrea Cornell from AMCHIP. Wanting to share on just briefly on the AMCHIP side. We're so thrilled to, in addition to be partnering closely with CDC as a part of the Erase MM initiative to support maternal mortality review committees, to also be coordinating closely with the National Center for Fatality Review and Prevention, which is providing technical assistance and support to FEMUR and CDR programs, very much to the end, as you shared wonderfully, Belinda, to support the establishment of FEMURs and as well as CDRs, but to support the establishment of FEMURs for community learning and intervention related to fetal and infant mortality. We're happy to send out information about the National Center for Fatality Review and Prevention and follow up to this call. But I just wanted to mention that our role, AMCHIP, on that steering committee is very much to facilitate coordination and collaboration across these entities because they are so reinforcing and so critical and, as many of us know, are so instrumental in being able to prioritize and inform action for prevention. And FEMUR has the particular and incredible power of having sort of a community implementation arm that in many ways has the opportunity to be so tremendously more equity-centered. So really exciting. I also wanted to mention that as a part of this 4-part webinar series, our 3rd webinar in the series, the date still being firmed up, that 3rd webinar in the series will feature our very own wonderful Dr. Cheryl Clark at AMCHIP, in addition to some additional wonderful speakers. And she'll be speaking to the power of FEMUR data, in addition to other data sources in understanding, prioritizing, and intervening in preterm birth. So Belinda, thank you very much for so wonderfully queuing that up. We're really excited for that webinar. I see a wonderful question here in the chat box from Teo, and I'm sorry if I mispronounced your name. Can anyone speak on some specific ways we believe doulas are able to participate in the reduction of preterm births?
This is Dr. Waddell again. I think that, increasingly we are seeing the benefits of doulas and that many organizations, including the March of Dimes, is supportive of the use of doulas. There are those, if you will, that sort of describe a lot of what happens in group prenatal care in terms of the secret sauce being the support that happens there. And that's really an important part of what happens with doulas. It's someone that's there with that pregnant mom and helping to support her and helping to be an advocate for her and with her. And so there certainly have been places like in New York City where they have been utilizing doulas that are seeing better outcomes where that has happened. So the notion of being able to use doulas, we are certainly supportive of, like anything that requires policies and reimbursement and those kinds of things to be able to sustain that. But I certainly think that there is a place for doulas in trying to address preterm birth, particularly from a disparities perspective.
Thank you, Dr. Waddell. This is Jessica from AmChip. I will also just say that our fourth webinar will be talking a little bit, hearing from some wonderful leaders who run programs that I think, I don't think they would call themselves doula programs, but are kind of beyond doula work and talking really about perinatal supports and how essential perinatal supports are, especially community-based, culturally reflective and culturally humble perinatal supports for reducing preterm birth and incidence of prematurity. So keep an eye out for webinar 4 for some an opportunity to really dive deep into into a little bit more about doulas and I think beyond doula care for sure. And I see a question here about from Susan about Oregon, and I'm wondering if we might, well, why don't I go ahead and pose that one now. So Susan says that we noticed that Oregon got an A grade. What do you think has made a difference in Oregon?
White people.
White people, yeah. I think it's a great question.
I wonder if
I'm wondering if I don't know if there's anyone from Oregon on the call, but I think that that's the opportunity that exists for all of us is that we often look at places that are having challenges. We also need to look at the places that are having successes and try to understand what's different about those places. Is it the overall demographics, and is that what's, why, if you've got a different demographic in the southeastern states, which we know exists, and there's significant disparities and overall worse grades of the demographics different in other parts of the country and other states, and that may be contributing to a difference in the grade, but also what are the different policies and systems that exist in those states that may be contributing to better access, to care, what's the insurance opportunity. So I think those are the opportunities to really learn from states specifically what's been put in place in your state and what are those lessons that can be shared and learned that might be applicable to other places.
Thank you so much, Dr. Waddell. I'm mindful of the time, and so I think I see some other great questions down here in the chat box that I want to make sure that we have time to address. So I think I'm just going to pose this one more question from Anne, and then what I will do is we will kind of officially conclude the webinar recording. So I'll turn the recording off, and then we can continue to discuss any state-specific questions with the March of Dimes team that you might have about the report card. So we'll keep this line open. Ooh, the thing went big again. So well, actually, while we're here, this question that I wanted to make sure there was a chance to answer from Anne: are there any specific resources for centering pregnancy activities that are culturally appropriate for our American Indian families? So if anybody on the March of Dimes team knows anything about that off the top of your heads, that would be wonderful, and I will also figure out what's going on here.
Jessica, I heard the tail end of your question. I'm not hearing a response. So can you repeat the question to see if I can try to help answer that?
Oh, absolutely. I'm so sorry. The question was, are there any specific resources for centering pregnancy activities that are culturally appropriate for American Indian families?
That, too, is an excellent question. I certainly know that there are models of group prenatal care that exist, across the country. The March of Dimes has a model of group prenatal care, supportive pregnancy care. There are other models that are operational. In Detroit, Michigan, they are doing a form of group prenatal care, but I don't believe that that is specific for the Native American community. So I'm not aware of something that is specific or uniquely tailored. Um, but certainly happy to take that back to our team to see if they are aware of anything.
Wonderful, thank you. So I do see folks typing into the chat box here, so please do continue to type. What I'm going to do at this moment is close off the recording. So while I'm turning this recording off, we're going to be here until 1:30, and if you have questions about the presentation that we didn't get to, or if you have specific questions, this is a great time to bring those up. So you're, again, welcome to just take yourself off mute using the *6 option, or you can raise your hand and we can kind of call on you. And thanks so much for the folks in Oregon who are chatting in here. That's really wonderful. Before we switch to our office hours, I do just want to thank our tremendous content experts, and I'd like to thank all of our attendees for being on the formal portion of the webinar today. We really hope you found value in this information for your work, and that you'll share the information with your colleagues. I also just want to quickly plug our next webinar. So keep an eye out for registration information for the next webinar on emerging research in preterm birth. We're so excited that Dr. Monica McLemore from the University of California, San Francisco's Preterm Birth Initiative is going to talk about research findings that really dig into the root causes of preterm birth. And this session is going to focus on the necessity to explore disproportionate distributions of risk factors across communities, and really talking about Dr. McLemore's research and others' research on toxic stress and resilience. So that's coming at the beginning of February 4th at 12:30 p.m. Eastern Time. So we'll be sure to send out information when we have the registration ready to go. And then just a quick reminder to please complete the evaluation for this webinar. You can either complete it now, or you can complete it when the link comes through in a follow-up email when we also send the recording. So I'm going to turn the recording off,